Hello everyone, welcome to the UBC Learning Circle, and we are here on Coast Salish territory, unceded Musqueam territory, Squamish territory, Tsleil-Waututh territory, and we're really happy to have you here. Today we have a special session, so we are hooking up with people from all kinds of places, and this is how it's going to work. So we're going to start the day with a presentation on the UBC Centre of Excellence for Indigenous Health, and we will do that presentation for about, it'll be a 15-minute presentation, and then there'll be some time for some feedback and discussion, and then we will have a presentation from the UBC Cedar Project, and that's a very exciting research project, and we'll hear from people in Prince George and Slachine and anywhere else? And here, of course. So that's what we'll do today. So welcome here. We have people on Adobe Connect. We have about 20 participants on Adobe Connect. So welcome. Hopefully you can hear us. Technical solutions are being worked on. And we have a few communities on video conference, and we have one person on teleconference right now. So coming right up, I'd like to introduce you to Dr. Link Kessler, and he is the director of the First Nations House of Learning and the senior advisor to the president of UBC on Aboriginal Affairs, and he is the co-chair of the Aboriginal Health Strategy Working Group. And this is a proposal that he's going to share with us, and it's really important that we get your feedback. There are a few people here that are part of that committee, and Chief Wayne Christian is part of that committee, and he may speak a little bit about what we're doing later. So coming right up, you're going to have a slideshow, and it's very short, just a few minutes, and then we'll get some of your feedback. So thank you very much. I'm going to turn it over to Link Kessler.
And we do know that people are hearing us.
Hopefully they are hearing us.
They're not.
They're not yet? Okay. Should we wait a minute, or? Because that's quite a few people online. It's 21 now.
I can't run the PowerPoint.
Okay. Sorry, everyone, if you could just wait. We'll just hopefully be back on board in another minute or two. We'll just take a quick pause. And I'll just mute us right here, but I'll just wave at you in 1 minute. All right, we're back on. Sorry about that, everyone. And I think we've got sound. Yay! Thank you.
Well, hi, everyone. It's really a pleasure to be able to speak with you a little bit today and tell you about some of the work that a group of people have been doing at UBC and with some community partners. And what we've been working to do is to try to devise a proposal for a Centre of Excellence in Indigenous Health that would allow us to bring together a lot of the work that's being done at UBC, but make it a bit more integrated and we hope more effective in meeting your needs and in providing a good, consistent place of contact for health programs, and then also identifying needs that people in communities have that we might begin to work to address. And we think it's got potential to make a really positive change. I'd like to take a few minutes just to take you through very quickly the main points of the proposal. And I think our real purpose here today is to tell you a little bit about it, but to hear your feedback and really ask for your help in making sure that the proposal that we're working with and that we're taking forward has got the right components and addresses things in a way which makes sense and you think may work well to increase our ability to work with you and improve Aboriginal health in BC and elsewhere. So that's our purpose. We really want to hear what you think, and we'll give you a little overview to tell you a little bit about the way we've been thinking about things, and then I really hope that you'll be able to share your thoughts with us. So in general, and if we can display the PowerPoint now, that would be great. As I mentioned a minute ago, one of the real purposes of forming a center is to provide a single coordinating point for work that's happening in health initiatives at UBC, but also a place where the collaboration with communities and providers can happen in the most effective and efficient way, so that we can really develop a collaborative approach that meets people's needs most effectively. And if you can switch to the next slide. We're seeing this proposal as operating in three main areas. One of them is research. The other is the curriculum that's available for training people in health professions at the university. And the other is the support of students, and particularly Aboriginal students, in pursuing careers in the health disciplines. And we do have one real focus and a guiding principle in the development of this proposal, and that principle is the principle of partnership. The recognition that we're not trying to devise something that does everything. What we're trying to do is find a way of connecting people and people who are doing work in all areas having to do with Indigenous health, particularly in BC, and finding a way to connect them and make all of the efforts that everyone is making work to their full potential. So I'll just go through these three areas a little bit and tell you what our thinking has been, and then close with a couple of other thoughts. So if we could have the next slide, please. One of the main areas that we're thinking about is research, and we think that research is extremely, it's a very valuable area, but it's an area that we know has been associated with a lot of problems in the past, where people from universities have come into community settings and conducted research and then disappeared with no clear benefit to the community, and in some cases maybe some adverse effects. So we are not in any way interested in promoting that style of research at all. What we're interested in doing is looking at some of the other projects that people have worked very hard to establish that are based on a very different principle, and that principle is collaboration between the people doing the technical side of the research and the communities for which the research can be valuable, and collaboration in which the design, the identification of what the research needs to be looking at is done in partnership, in which the design of the research is devised in partnership and conducted that way, and in which the results are always shared back with the people who participated in the research. And there's a clear ability of people and communities to comment on what they see the value of the research having been, or what needs to be done further to make it more useful. So I think in the later part of today's session, you're going to be hearing from a project which operates in this model and has been developed as a collaboration between communities and university researchers. And this is the kind of research we think is really important, and people need to know more about it and understand it better. And people at the university who are beginning their careers, or even people who are well along in their careers but have not operated in this way, need to know more about its benefits and understand how it works, so they can begin to do research in this way. So key aspects of this kind of research is that the research is driven by community needs and what the communities identify as urgent and important, and that it's designed with input all along the way and feedback from community partners as to how the research is progressing and what needs to be adjusted to have it work better, and that the results speak clearly to communities in ways that it can be fully utilized. Along the way in that research, we think it's really important to involve community members in the work and to build capacity in the communities to work with researchers, and encouragement to community members to become researchers and to pursue that as particularly for younger people in the community to really think about health research as an occupation that they might want to pursue. So that's one of the main things that we would hope that the center would do, which is define these more effective research models and really work with people to see more of them and to train people better in understanding them and conducting them responsibly. Could I have the next slide, please? There are many health discipline units operating at UBC, and they train people in all aspects of health for many different careers. We're very concerned that in that training, people are not given information that would help them and understandings that would help them operate effectively with Aboriginal people, whether it's in the context of remote communities or urban centers. And we think it's very important that medical training and health careers training include very strong components of giving people an understanding of the people that they will be working with professionally and how the relationships that they form can be formed much more effectively. So we're interested in taking some of the curriculum that has been developed already, and Leah is one of the people who's worked very hard in these kinds of developments, and developed with community participation, strong community participation, and think about the ways that kind of education can be offered more broadly to more people in health, more students in health careers at UBC, to make them more responsive professionals when they go to work in their professional lives. Since this proposal has been drafted, we have been taking it around to and making presentations in different faculties to different programs. And I would have to say that the response in those programs has been really very positive to the idea that we need to be training people better, and that it's an important priority. I think what we found is that people in a lot of those places are not clear how to go about doing this, and they don't want to make mistakes, but they would welcome some advice as to how in their areas they can provide better training that's more culturally sensitive and offers people a much better ability to work with people in different communities, and certainly with Aboriginal communities. So we're very interested in using the center to share some of that knowledge and develop that curriculum much more widely. Next slide, please. We think it's very important to increase the number of Aboriginal students who study in health professions at UBC and elsewhere, and with the intent of increasing Aboriginal participation in all of the health professions at the professional level and technical level, and really at all levels. And that by doing this, we're not only equalizing opportunities of employment and giving people a chance to have very satisfying careers, but we're also developing the community knowledge base that will provide better input into all of the things we've been talking about, the research, the training, by the involvement of Aboriginal people at every level, and people sharing their understandings and making that a part of the educational environment and then the professional environment as they complete their studies and move into professional work. So we're very interested in encouraging students from a young age to think about health careers as something that is a real possibility for them, and giving good advice to people as to the decisions that they should be making in their education that will provide them with the base to study in health careers at the university, and then bringing them to UBC and giving them the kind of support and the education that will make them effective professionals. So we have a very successful program in the medical school for training Aboriginal doctors, and that program is small in some respects. It doesn't operate with hundreds of students. It operates with each year by bringing in a small number of students. But over time, it is increasing the number of Aboriginal doctors in BC and in Canada significantly. And there's a lot of interest from other areas of the health professions as to how they can do something similar. And again, what they need is they need the experience, the benefit of the experience that's been gathered through this program in the medical school. But then also they need ways of thinking about how the specifics of their discipline can modify that model to work well for them. But again, there's a lot of interest in doing that, and what we need is a way to work with people across the disciplines to increase the number of Aboriginal students entering these fields. Next slide, please. I mentioned earlier that the guiding principle of our proposal is partnership, and the kinds of partnerships that we've been thinking about work in many different directions. Most definitely, the key partnerships are the ones with communities. There are many different kinds of communities and agencies that we're thinking about in this regard, and all of you and the work that you do with working for good health outcomes in your communities. Those are critical partnerships that we would like to see strengthened, so that the work that we're working effectively with the things that you're doing, we have a clear understanding and are always making sure that our understanding is current of not only the work that you're doing in the communities, but the things that we might be able to assist with or provide some valuable piece that would be of benefit to you. And so that communication is really vital to maintain that kind of accountability, but also to be sure that the efforts that we're doing at the university are relevant to the actual needs that you are defining. We're also really concerned to develop partnerships across the disciplines at the university. One of the real challenges of a university like UBC is simply that it's huge. It's got many, many different units in it, and people are often doing work that's quite relevant to what someone else is doing in some other part of the university, and they have no way of knowing about each other. And that's a lot of lost opportunities there. So we think that this center will be one way in which we can connect people inside the university make them more aware of each other's efforts, and offer a more integrated approach to health disciplines in our relationships with you and the communities, because we are talking to each other the way we ought to be. We're also thinking of partnerships on the global level. There are units at UBC who, for instance, have very good relationships with programs in the United States, such as the American Indian Health Program at the Johns Hopkins University, which is one of the leading ones in the United States. But we also have other units that have partnerships with universities in Australia and New Zealand and elsewhere. And all of the ways in which people in these different places are devising approaches to health issues and to relationships with communities are important, and they're things that we can learn from. And the things that we develop here are things that we can share with them. So we're also very interested in being part of those networks, and think that by doing that we can make the most of our capability to develop good approaches and take full advantage of the work that's being done all over the world and bring it here. Next, please. Our real aim, of course, in thinking of this design is to come up with a practical structure that we think can actually work to accomplish the things that I've described. And it's all with a single intent, and that intent is to improve the health outcomes and the well-being of people, Aboriginal people in the many communities, both on reserve and in urban settings, that are throughout our province and more widely in Canada and elsewhere. We think that the partnership model and a more integrated approach to the work that we do at the university can do that. It can make a real improvement, and that's why we've been putting work into this proposal. But we want to make sure that we're on the right track with it. And for that purpose, we're happy to have the chance to speak with all of you today, and to hope that you can help us in identifying things we may have missed, or we would love to hear things that you have heard that you think will work and would be valuable, so that we make sure to keep them foregrounded in this proposal. But we really appreciate your time. And on the screen now, you'll see a couple of ways, besides this immediate opportunity to talk, for further through which you can send us some further thoughts. And one is through the website that you'll see there, which is aboriginal-health.sites.olt.ubc.ca, and it's on the screen. And you'll find the full proposal text there, but also a way in which you can contribute feedback that way, which is quite easy. But you can also just send us an email at aboriginal.health@ubc.ca. We'd really appreciate your help in thinking through further stages of this proposal, and really appreciate you taking the time to think about it with us today.
Thank you very much, Link. I'm wondering if there are any questions from the floor or on Adobe Connect, or any comments or any thoughts.
I think everyone out there is falling asleep with that long talk.
Mm-hmm. Got a few people typing.
Can I say a few words? Can you hear me?
That would be wonderful.
Thank you, Chief Wade.
I'm Chief Wayne Christian. I'm actually in our the Spelician Health Center. We're doing a health fair here today, so it's pretty awesome. I'm just wondering, Link, I know that you've given sort of a broad picture, and I've been involved in this process not from the very beginning. I became involved with it. And what interests me, and I think what's really important, is how we can actually take the Center of Excellence, not only in terms of the traditional sort of medical health model, but also how we can begin to look at and address the issues of our traditional practices and how we can stand those up. Because I think a big part of what we're seeing is that there's got to be a combination and an integration, if you will, of sort of traditional medicines with standard practice. When we did a presentation, to the medical students, it was really interesting. I think they're grasping the sort of the medical field as really a high stress environment. And I think some of the practices that we hold, whether it's within ethnobotany as it's called, or the medicines, malama, or whether it's in our ceremonies, that I think that the individuals that are going through the Aboriginal sort of doctor program could benefit from those things. Simply because it's things that can be done in the community and doesn't necessarily have to be done within an institution. So I think that that's what I see the benefit of this strategy and how it's moving forward. And I've been, like I said, a part of it, and I think it's really would be a benefit to the institution, but more importantly, a real benefit to the move towards community-driven, nation-based processes as one of the directives for the First Nations Health Authority. And so I think it's really a critical piece of work, and I just want to say thank you to yourself and the others that continue to do that within the institution. I think your biggest challenge is within the institution, simply because the institution itself is very old school, very Eurocentric, and you have a tough time breaking down those walls. So, just my comments.
Thank you for that. Thank you for that comment, and also for highlighting that aspect of the work, which actually I did not describe very well. And I just want to add something to that. And I think, speaking of the medical students is a really great way to think of it. We now have quite a few programs across UBC that work with Aboriginal communities. And whenever UBC students have the opportunity to work with community members, whether it's through going to Musqueam to study the Hunkaminam language, and that's taught in part by a community elder, or whether it's people in the planning program working with people who work on planning in community contexts and working with elders and other kinds of leaders in the community. They always cite it as one of the most important aspects of their educational program. And I think that speaks to the power of their understanding of those community processes and what's available through them. And it's sometimes hard to get people who have worked out of a very technical or very scientific framework initially to understand why that's important until they have an experience of it. And generally speaking, they become pretty enthusiastic about it. So I think it is a way for people to become better familiarized with the value in that work. But I think it's also, as Chief Christian has just identified, it's also a way to put a focus back on the ideas of wellness and maintaining balance and working with people who work in communities to that end, and understanding how vital that is to health outcomes and how much it complements the other approaches that are developed in other ways through the scientific medicine and those kinds of things. So I think forming partnerships wherever we can do it that make those relationships stronger and allow people to see those things really makes an improvement, not just in Aboriginal health outcomes, but in what Aboriginal communities have to offer people at the university for not only for their professional development and understanding, but personally for their well-being and their ability to see things a little differently in ways that can benefit them. So I think that is a real aspiration for those of us who've been working on this proposal. And having Chief Christian involved has been really important in constantly keeping those possibilities at the forefront. So I really, really appreciate the comment.
I have a couple of comments here from online that I would just like to relay. And one is from Sue Chichu. She's in Statlium Territory, Lillooet. I appreciate the opportunity to provide input on this proposal, and I look forward to bringing this to our hub committee. So there are hubs in all of the communities, are in different nations, and she just believes it's a positive, inclusive approach. And similarly from Ken Solanas in Burns Lake, he says what's being shared is long overdue in the support in education and working with Aboriginal communities. We have a question here from Nancy La Liberté, and she asks, how will this Centre for Excellence intersect with the First Nations Health Authority? Will it be a BC-focused institution? And then I'll ask the second question. BC-focused institution.
I think one of the things that has driven the development of this proposal at this time was the awareness of people at the university of how much the landscape in Aboriginal health is changing in BC with the development of the health authority. And the concern that at present we really didn't have a very well-defined point of contact for people from the university to interact well with the health authority as it formed. And we think that is extraordinarily important, that there has to be some way for that relationship and the information that needs to travel back and forth between the university and the health authority to be really clear and functional. That being said, we're also aware of the fact, and we're reminded in our own thinking and by partners that we work with, that not all Aboriginal people will function through the health authority, and that we also need to be, in our thinking, attentive to urban populations and people who would fall outside of the health authority's mandate. There is, I think, in terms of the second part of the question, there is a real concern that we maintain a strong focus in BC because we have there's a lot of important work to do here and a real responsibility for UBC as a research institution in BC to meet the needs of people here. As I said before, we look to international partnerships and more broadly to being parts of Canadian networks because we would assume that UBC has things to offer to those partners, but also because by maintaining contact with them, we stay up to date with all of the developments that are happening in other places that may be useful for people here in BC. So I think the focus is BC, but with an awareness of these larger frameworks as well.
Okay, and I think I'm going to just ask one more question, and then because time will run out, and I'd really like to come to the Cedar Project now. So for all the questions that we don't get to, I'd appreciate if you could go to the website and email, or you could direct them to the Learning Circle, no problem, and we will forward them to the right people. We really value your input, thoughts, and concerns. Very important. So the last question that I have here is, what are your thoughts about providing cultural competency training for researchers working with Aboriginal communities?
I think it's really important, and my work at the university is not in the health disciplines. Before my current role, I was the chair and director of the First Nations Studies program in the Arts Faculty. And our program in the Arts Faculty in First Nations Studies is a research-driven program. So one of the things we do is train every student who comes to our program and build their capacity to work with Aboriginal communities and organizations as researchers. We know that they cannot be effective in that role if they don't understand the circumstances and have a way to think about the circumstances of the people they'll be working with. Whether our students are Aboriginal or non-Aboriginal, we know that giving them ways to think not only about differences in culture, but about who they are and what they bring as people coming with skills from the university into settings and communities where other people have other forms of expertise, which are certainly every bit as important as what they bring. But knowing how they can become part of a team and bring value to that team, but operate with a clear recognition of other people's culture, but also their strength and their knowledge. That's really critical. It's the basis of them being effective. And if we fail to train them that way, we're failing to train them. So it's extremely important. It's certainly extremely important in my thinking, but I've been very happy to work with this team in the health disciplines because I think it's foremost in their thinking as well. And again, we have some work to do to make sure that that thinking is shared very widely at the university, but I'm quite encouraged by the reaction we've gotten from people as we've taken this proposal around. So I think it's certainly something we can work towards with some speed.
Thank you very much, Link. Hi, Chikao. Siam, thank you very much for everyone for listening to this part. And we're now going to move over to the Cedar Project. And again, all of your questions, thoughts, praises, concerns, now or later, please come to the website at health.aboriginal.ubc.ca or email at aboriginal.health@ubc.ca. Thank you so much. And now, I am so pleased to welcome Chief Wayne Christian again. Look at you, multiple roles. Cookie. Wayne Christian from Splachine doing a health day today. Thank you. And it looks like, just seeing in the background, that it's going very well over there. Lots of activity behind you. You can't see them, but they're doing all kinds of things back there. So, yes. And could the person that's on teleconference please mute? Thank you very much. And then right beside me, we have Margot Pierce from the School of Population and Public Health. She's a PhD student there, and she's been working with Dr. Spittle and Dr. Martin Schechter on this project for a number of years, part of the Cedar Project. And we have the lovely Vicki Thomas, whom I had the pleasure to meet in Prince George, and she's the project coordinator for the Cedar Project Partnership. So we have all three of you here, and I'm just so thrilled because I've heard about this project, I have quoted this project, and I've been impressed by the work that you've been doing. So I'm really excited for you to share where you're at now with it. So it'll be great. So is everyone okay to go? Can I just turn it over to you?
Can I just say something? Sorry.
Yes.
I don't know what's going on today, but I'm not able to show the PowerPoint like I usually do.
Okay.
So you're going to see the whole chat screen, and I know it's really distracting, but that's the best I can do. Sorry. I don't know how it's working.
All right.
So when you're ready,
All right.
go over and that's what you're going to see.
Whoever's on the telephone, could you please mute? We can actually hear everything that's going on behind you. Thank you.
There we go.
Thank you.
Okay, and we're fixing the gray screen sorry for those that are on Adobe Connect. Okay, and did you want to take the lead on this, or Vicki, did you want to? Or?
Actually, Vicki will be starting off today.
All right. So welcome, Vicki.
Hi, can everyone see me and hear me okay?
Absolutely. You look beautiful.
Oh, thanks. So my name is Vicki Thomas, and I am from Oikino Nation on the coast. My mom is Lena Thomas, me Hanyus. My father was Tom Thomas. I'm from the house of Zixie Wallace. I've been living and working in Prince George since 1992, and I have been working with street kids since 1994. The information I'm going to share with you is about the work I've been involved with in the Cedar Project for the last 10 years. Just to preface, I don't know all the answers. I'm still really young and naive and ignorant, and I have a lot to learn. And all the information I'm sharing, I don't want to offend anyone, so I just want to preface everything by saying that first. I don't know if everybody can see the PowerPoint or if I should just get going. I don't see the PowerPoint presentation up, so should I just start with my slides, start going?
Yeah.
Okay.
How's that?
That's perfect. So the first piece I'm going to speak to is about how we've created balance with the research world and the Western ethical guidelines that we have, and then what I call our Indian ethics, making sure that we do things in a good way. So I'm going to do the first part of the presentation. Then Marco's going to speak to the data, and we've saved the best for last. So Kupti Christian is going to finish off with a lot of big and important stuff that we've done with Cedar. So if we move to the next slide. There we go. This is a teaching I received from one of our elders here in town named Earl Henderson. And I just want to preface and talk about how our communities were before colonization and before the residential schools. And this is a great visual that Earl uses when he explains it to us and then the young people that we work with. And Earl always talks about how traditionally in our communities, our elders and our children were at the heart of our communities. And our elders were there to teach and guide our children. And surrounding our elders and our children were our women. And they were the ones taking care and making sure that our elders and children were okay. And surrounding our women were the men, and they were our providers and our protectors to make sure that we had enough food and everything. And then surrounding them is the rest of our community and our extended family. So when the way Earl explains it is that when the residential schools came into effect, the opposite effect happened of a volcano. Instead of going out, our communities just collapsed inwards. There is no children at the heart of our community, which left our communities lost. And next slide, please. This is not teaching that's specific to my people. This is another one of Earl's teachings. And this is one about the medicine wheel, but it kind of transcends and includes all the different aspects of what our all our communities have in common. And that's about looking at health, not just in our physical health, but our emotional, our physical, our mental, and our spiritual health. And it's about our communities are all represented here, our children, our families, our adults, and our elders. Everybody is there. Next slide, please.
Vicky, can you hear me?
Yeah.
Yeah, on my side, I still only have the first slide. It hasn't come to the fourth one yet, so I don't know what's going on. I just see the first slide still.
Laura, line 2.
Okay, maybe Catherine or somebody can. I don't know how to fix that. I don't have the slides here, Wayne. Catherine has them.
Okay, I just just so that whoever's doing the slide, the PowerPoint slides, only still here at this location, I still see just the first one. So.
Okay, we'll get that.
Yeah, just keep going. Just maybe just me.
Oh, my screen
Yeah, your
says
screen is frozen. Yeah,
My-
you should. I think, Wayne, your screen is frozen.
Somebody new running their system too on Health Canada Learning System.
Vicky, are you still there?
Yeah, I was just waiting to see if I should start or keep going or what.
Oh, just keep going.
Okie dokie. So the Cedar Project is an Aboriginal youth health study. Our participants, when they enroll in the Cedar Project, have to be between the ages of 14 and 30, self-identify as being Aboriginal, and use illicit drugs within the previous month of enrollment. So just so everybody is clear, we don't need government ID to identify us as Aboriginal or not. There's many of us that don't have status cards or are Métis and don't have a Métis card. So if people are able to explain their lineage and know where their roots come from, then that's what we use as a guideline. And we do a urine test to confirm whether or not there are illicit drugs in a person's system. We recruit people. We do that via word of mouth. Other participants recruit other people. Staff go out in the community. Other agencies refer as well. We do have, as I was saying in the very beginning, our ethics and guidelines, but we have two types of ethics. We have the research ethics that we have to follow, and we also have what I call our Indian ethics, to make sure that we are doing things in a good way. We have always had a partnership, which I'll get into later on, and they're made up of different Aboriginal stakeholders in each territory that we are in, that make sure that we're doing things that are relevant in that community, and we're held accountable to each community that we are in. We administer a baseline questionnaire with participants, and they get blood work to test for HIV and Hepatitis C, and we see participants every 6 months. Next slide, please. These are some of the issues that aren't generic. They're not specific to the Cedar Project. These are research issues that just come with our communities, and that people have these perceptions of Aboriginal people in health research, that we get research because we're abnormal, and that's really part of the history that stems from a long time ago. And there's a huge mistrust that our communities have within research. As history has shown us, our research, people have come into our communities, taken information, taken blood samples, taken artifacts, and nothing's been brought back into the community. And in the past, tissue samples have been used for other things than what was guaranteed that it would be used for. So there's a lot of mistrust with our people, and rightfully so, about wanting to participate in research. So when working with our communities, people need to remember that you have to pay attention and look out and have community partners. If the community doesn't want the information, going in and doing the research it's not going to happen. Making sure that you do things in a good way is very important. Following the confidentiality, all these sorts of things I'll get into quite a bit later throughout my whole presentation. Next slide, please. So we frame all of our research within the Cedar Project based around the historical trauma that we have an understanding already, that we know that, say, I never went to residential school, but my mother spent 15 years there. I know that that legacy has affected me and my family today, and that we've had a loss of our lands, our culture, all these different things, but yet we know that we are a strong people, and that we are still here today to show how resilient we are. And that to really explain that addiction is one way that our young people choose to deal with the hurts in their life. Next slide, please. So we get our funding from the Canadian Institute of Health Research, which is federal funding. They have a policy paper that talks about guidelines. It's not, they're guidelines, it's nothing set in stone. People don't have to follow it, but this is CIHR encourages everybody to follow these guidelines about working with Aboriginal specific communities when you're involved in research. So the next slide. The Tri-City Council, let me get the title of it, I always forget. the Tri-Council policy statement around ethical conduct for research involving humans has a specific section about working with our Aboriginal communities. And it talks about incorporating and understanding our way of knowing and our way of being, and that it's our communities that ultimately own this research, and that we have support from the leadership in each territory that we're in, and that we have a partnership that can govern and oversee us. That we take our confidentiality serious. A lot of times in the past, our people's confidentiality has been next to non-existent. And knowing that it's our Aboriginal communities that own this research, that all our participants in the study are from our communities, that ultimately, even though this research is based out of St. Paul's Hospital in UBC, ultimately it's our partnership that governs us. I talk about it all the time. People say, who is your boss? And I have many bosses. I have my direct supervisor through UBC, Dr. Spittle, but ultimately the big bosses that I'm responsible to are our partnership and our elders in that partnership that make sure we do things in a good way. Next slide, please. Okay. So the Tri-City Council agreement also talks about building capacity, and I'm a perfect example of capacity building. I don't have my degree yet. I've got 2 years of post-secondary education. I don't have my master's, but yet I've been asked to be the coordinator of the Cedar Project and build on the skill set that I have and the knowledge I have in the community. Also to make sure that the information is understandable and can be broken down into layman terms, because when I look at our research papers and all the academic writing, most of it still kind of goes over my head. Understanding that our biological samples, so the blood samples that our participants share with us, they're on loan to us, they're not ours to keep. And that our partnership is there every step of the way when we're starting to review our data, to look to forming the questions on the questionnaire, to how the information is going to be written, how we're going to go public with everything. Next slide, please. So our partnership has been here from the start since 2003, and our partnership governs and oversees us, and they oversee everything from our research design to the types of questions we're going to ask to what they know is going on in their community and the information they need that is going to be relevant for them to try and effectively make change. We have quarterly meetings in each season. Once in a while it can be at times difficult to get everybody together. Once in a while we might miss. If we have emerging things coming up that are important, we quite often meet via teleconference. Our partners make sure that we're always doing things in a good way and that the ethics are held up to standard. Like I said, they oversee the communication and media strategy, how the results are being interpreted, and they develop all the recommendations for programming, so different things that we might be able to do. Next slide, please. So this diagram kind of shows how we've tried to build the Cedar Project the same way that our communities used to be traditionally, where our participants are at the heart of our community, and that it's our frontline staff that are there with our participants to hear their story, to share their tears, to offer any referral in the community to help bring them to appointments. And then surrounding the staff is our partnership, and they're the ones that oversee all of the Cedar Project to make sure that we're always doing things in a good way, that our elders are there to guide us and to hold us accountable, to oversee our knowledge translation, our ethics, just everything. And the little bubbles around to the corners are the different supports we have within St. Paul's Hospital and the university that help grease the wheels to make our community work. Next slide, please. So these are our partners. I just wanted to list them off and acknowledge them. They have been, oh, back one, please. There we go. Violet Bazoki and Earl Henderson are our two elders on the partnership. Earl Henderson is Métis and Sioux. Violet Bazoki is from the traditional territory here, Clay-Tene. We have Katharina Patterson from Haida Gwaii. We have the Prince George Native Friendship Center, Carrie-Sicani Family Services, Splatsin Nation, Adams Lake Indian Band, Nisquamish Indian Band, Positive Living North, Healing Our Spirit, Red Road, CAN, the Canadian Aboriginal AIDS Network, Vancouver Native Health, Central Interior Native Health, and All Nations Hope. And you can see there's Wayne hard at work in that one picture. Next slide, please. So we have the main partnership, but the partner also breaks down into different committees, and partners can take a more active role in things that they want to specialize in, where some partners really want to be heavily involved in the publication and how the data is reviewed, how the data is written, and how it gets communicated out into the public. We have a trauma committee that deals with the different trauma that participants have disclosed. They're always involved in the presentations. One of the unique things I think that we do is our mentoring program. So no master's or PhD student can take a part of Cedar Project and do their thesis work with us without signing an agreement with one of our partners and being agreed to be mentored by them to make sure that they can understand our history and the issues through an Aboriginal lens. And our partners who are mentors have always gone to all the different thesis defenses that our students have gone forward with. And they sit on the thesis committee. Next slide, please. We also follow the OCAP principles. I don't know if everybody is aware of them, about ownership, control, access, and possession. And this is the guidelines with which the partnership runs by, knowing that ultimately it's our partners and our communities that own this information. It's not UBC, it's not St. Paul's Hospital, that they have control over how things are done, that we have access to it, and ultimately we are the ones who own it. I have all the samples of these different documents right here. I don't know if you can see. So if anybody is interested in finding these, they can just email Catherine and I can send everything to her. Next slide, please. So to give an overview around HIV among our people in Canada is specifically in BC, and I always talk about it with the young people when they're coming into the office. The reason why we're here is that our people make up, I think it's 4 or 5% of the whole population in BC, but we make up, I think it's around 14% of all the new cases of HIV coming out in the province. So that's not right. The rates are really high, and that there are very few studies that give background and understanding of what our people are going through and why we use drugs. Next slide. So this, I'm really going to talk about the beginning days of Cedar. So the PI, the principal investigator of the study, Dr. Patricia Spittle, was involved back in 2003 with the study called VITUS, which was the Vancouver Injection Drug User Study. And Patty did all her PhD work in Uganda, and so when she had coming back from Uganda and started working in the downtown east side, she was wondering if what was going on in Africa was similar to what was happening with Aboriginal people in the downtown east side. And what they found was that our people were at higher risks of becoming HIV positive than other ethnic groups. And that wasn't right. So when they started to present the data, they came up to Prince George and presented at a conference, and numerous different community members from different agencies approached her and said, if you think this is something that's specific to the downtown east side, you're wrong. This is something that is occurring up in Prince George as well, and we need to have this type of research to back up what we're saying so we can go to our funders and lobby for better and more specific programming. Next slide, please. So pretty much I've already told you why Prince George was picked. And so in the beginning we wanted to find out, is there a simmering epidemic of HIV up in the north? For many of the clients that access the needle exchange program here in town, many are Aboriginal. There is concerns that there were a higher number of rates of Aboriginal people that were becoming HIV positive. Overrepresentation of our young women involved in survival sex work on the streets, and there's very few studies that offer information about what's going on with at-risk young Aboriginal people. Next slide. So I basically already talked about that one, sorry, so we can go on to the next one. So we've been in Prince George and in the downtown east side since 2003. We opened our office in the Secwepemc territory back in 2011. We originally tried to open an office in Kamloops back in 2007, and unfortunately we hit there when the city implemented a very strong police sweep and a cleanup of the North Shore, and we were not very effective at all in recruiting people in almost a year. So we couldn't justify keeping an office open, spending that amount of money when ultimately this is federal funding. And our partner, specifically Kripke Christian, was talking about you can't shut down. You have to think outside the box. Our territory is very different, and what worked in Prince George and what worked in Vancouver isn't going to work for you here, so you have to design a different method. They still, Wayne was telling us, we still have young women involved in sex work. We still have people dying of overdoses in our community. There's heavy gang involvement in our territory, and there's a lack of support for our young people. So the Shuswap Tribal Council did a resolution to invite us to stay in that territory. And so we designed a totally different method that's been really effective. The staff spend one day in Chase, one day in Salmon Arm, Enderby area, one day in Kamloops, and we have a very mobile office. So we have funding from Gilead to purchase a van so the staff can really go and meet people where they're at. Yeah, next slide please. This is just a visual in case anybody doesn't know where Chase and Prince George is. Next slide. So like I was saying, we were designed to be able to bring the evidence. As we all know, The different government agencies that provide funding always want what they say evidence-based information in order to provide programming. So they want the research and the stats. So we've been here for 10 years. In the academic world, they call that a longitudinal study. And we look at the impact of intergenerational trauma on negative health outcomes. So looking at how does our past affect our health, and looking at what makes our young people strong and makes our people still survive. And we also have a really cool part of the study is our case management. We call it the blanket program, and this is designed for people who are HIV positive. And this is an opportunity for the young people who are positive to say, we're a blank canvas, and they can just tell us how they want us to support them. And hopefully over time we'll be able to see with the support that they get to choose how they want that to be, that their health will improve. And too many of our people are HIV positive. We had a young man in our study that passed away within a year of becoming HIV positive, and he died at home. And sorry, I always get upset when I talk about him. There's no reason why he should have died at home, but he had such horrible experiences with our healthcare system that he refused to access healthcare, even with support. And he could be alive and well today if he didn't have such maltreatment. So we're really hoping with the blanket program that we can provide that support and see continued better health outcomes for our young people. Next slide, please. So currently we have about 900 people enrolled in the study between Vancouver, Chase, and Prince George. They come in and do interviews every 6 months with us. We ask different questions around different things that may put them at risk for becoming HIV and hepatitis C positive. We ask around traumas that, very hurtful things that may have happened in their childhood, and things that make them strong now, and how they keep going. And we ask very intimate, detailed questions, and the participants never cease to amaze me at how willingly we are able to trust, even though we've been continuously hurt. They're amazing kids. Next slide, please. So this last slide, I always find it really silly when I see the word cultural safety and how that term is used around so much. And 10 years ago when I started at the Cedar Project, I didn't know what cultural safety meant, but it's something that we do in the office, and it's about making the space safe for the participants. So they call that cultural safety now. I just called it doing things in a good way, in the teachings of my mom, the teachings of my aunties, the teachings of the women in my community. And so people know when they come into our office, it's funny, Patty and I look back at it now and laugh, but I had my own preconceived notions of what research was compared to what I know now. And quite frankly, my friends and family asked me if I had my head up my butt, and why would I want to come and work in research when historically research has treated our families very poorly. And my response was, if this research is going to be in my community, I can make sure it's done in a good way. So we try to make our offices as safe as we can. So that's about treating the office like our home. So when people come in, they should feel like they're at home. If they want to use the phone to make a long distance phone call, they're more than welcome to. If they want to sleep a shift away on the couch and we're not going anywhere, they are welcome to. If they want a sponge bath in the bathroom, as long as they can clean up their own mess, they're welcome to. We try to bring in as much traditional food on special occasions as we can, and Kupti Christian has been one of our biggest supporters, him and Lou Demerai, about making sure our offices can have traditional food, and it really means a lot to our participants. We went totally traditional last Christmas, and normally our office ends up with about 30 people for our Christmas dinner. And we told everybody no turkey this year. It's all salmon, moose meat, deer meat. And we had over 60 people come within 1 hour. And for me, an Indian woman's nightmare came true. I've never in my life, personally or professionally, run out of food, but it happened. We're also a safe place to be if people are high. We don't normally see a lot of violence that comes out when people are pretty high. The bigger concern is around when people are intoxicated, and that's when we usually see violence come out. We are a police-free zone. It's really important for the participants to know that. If the kids thought that the police were welcome on site, they wouldn't think that their information was safe with us. So if police come on site, we have to walk them off property and talk to them outside where anybody can hear. And the participants really value that, and they end up governing the space themselves and making sure that it stays safe. So I think that's it for my part of the presentation. Thank you, everybody. And if you have questions and we don't get to them at the end, you can email, and then I can answer whatever I can. And I'll leave it with Margot now.
All right, thank you very much, Vicky. Aichka, Masicho, that was wonderful. I learned a lot watching that. That was so great.
Okay, thank you, Vicky. I just want to say quickly that I've been mentored within the Cedar Project mentoring program through the partnership since the start of my research training through my master's and now through my PhD. Katharina Patterson and Earl Henderson have been instrumental in my development of my own ability to understand and to speak to these issues, and so I'm eternally grateful for their support and their mentorship and guidance. I'm just now going to give some of an overview of some of the studies we've published and to give you a sense of the kinds of information that we gather through the Cedar Project study. Next slide, please. Our first paper was published in 2007. Sorry, next slide, Catherine. It went backward and then forward for some reason.
Okay. So should be this one, right?
Next one, please. There we are. Perfect. Thank you. Our first paper was published in 2007 in the International Journal of Circumpolar Health. And this study estimated the prevalence of HIV infection at baseline and described risk factors associated with infection. Next slide, please. The important findings of this paper were that at baseline, 8.5% of participants were HIV positive and 35% were hepatitis C or HCV positive. And this rate was much higher amongst participants who reported injection drug use. Not surprisingly, the majority of people who were HIV positive were from Vancouver. However, we also found that there was no statistical difference in the number of participants who were HCV positive in Vancouver and Prince George. And given that hepatitis C is often the harbinger of HIV infection, this result was really concerning and underscored that ominous warning that we had that there was a simmering epidemic, perhaps of HIV in the north. We're presently working on an updated HIV analysis looking at HIV infection over time, and so hopefully we'll have some results in the next 6 months or so to see if that is indeed what's happening. Factors significantly associated with HIV at baseline in the final model of this study included sexual abuse, being located in Vancouver, and having a longer duration of injection drug use. The relationship between sexual abuse and HIV infection was deeply troubling, particularly concerning the relationship remained despite adjusting for syringe sharing and cocaine injection in the multivariable model. Next slide, please. So this finding then led to the partnership asking us to look more closely at health outcomes associated with sexual abuse among Cedar Project participants. This study was published in the year 2008 in the Journal of Social Science and Medicine. And I can certainly attest to this being a difficult paper to write and a highly sensitive one at that. Next slide, please. In this study, we found that nearly half of the participants had experienced childhood sexual abuse, and the majority of those participants were women, although we suspect there may have been some underreporting amongst the men in this study. It was highly distressing that the median age of sexual abuse was 6 years old, and that prior to their baseline interview, 2/3 of the participants had never received counseling to deal with the abuse. Some of the a priori risk factors that were associated with sexual abuse included sleeping on the streets, suicide attempts, involvement in sex work, and in line with our previous study, being HIV positive. Moreover, this study revealed links between generations of trauma related to the residential school system and foster care with sexual abuse. We found that a significantly higher proportion of participants who had had at least one parent who attended residential school and participants who had been in the foster care system had also experienced sexual abuse. So throughout the writing process of this paper, there was extensive consultation with the partnership and elders who support this study in order to write this in a good way, and also in the process of publishing and in media relations. Next slide, please. The impact of making these results known was heard all across Canada and in the media, and the way it was talked about has received recognition from Aboriginal and non-Aboriginal communities alike. We got, anecdotally, we got a letter from a nurse in North Dakota who had thanked us for the way in which this issue had been written about. To date, we've had a lot of media interest in this story, including a publication in the Globe and Mail and a panel interview on CBC Radio's The Current. Several recommendations have been made based on this research, which we are trying to get support for, and I believe Cookie Christian will be speaking to that later on. Next slide, please. This is just another picture of some more local media related to the article, and this is from a popular community newspaper. And an important quote there from Cookie Christian saying that these numbers are relative. Next slide, please. And this was a follow-up editorial in The Lancet written by Cookie Christian and Dr. Spittle, which spoke to the intergenerational trauma relating to HIV risk amongst young Aboriginal people in BC. Next slide. The next study I wanted to draw some attention to was our paper in hepatitis C prevalence and incidence amongst Cedar Project participants. This study was very important to the partnership, given that there was a high hepatitis C prevalence we'd found in our baseline study, particularly amongst participants who injected drugs, and because we found that similar prevalence between Vancouver and Prince George. Indeed, this study found that there was a higher incidence of hepatitis C in Prince George. Although that difference wasn't statistically significant, it confirmed that there, in an absence of meaningful interventions to prevent transmissions in the north, the epidemic was indeed spreading. Furthermore, in the multivariable model of factors associated with hepatitis C infection at baseline, we found that the odds of infection were significantly higher amongst women, amongst participants who had injected opiates daily, participants who had reused syringes, and amongst those who'd been injecting for a longer period of time. Moreover, we found that participants who had a parent who attended residential school were twice as likely to be hepatitis C positive compared to those whose parents did not attend residential school. This finding had very important implications for the Cedar Project Partnership. While the previous research had suggested that drug use is a way in which young people are dealing with the complex effects of poverty, discrimination, loss of language, culture, and territories, and that there was trauma related to the residential schools, this was the first study, to our knowledge, that found a statistical link between historical trauma and communicable disease. In this paper, we argued that acknowledging the intergenerational trauma related to residential schools and foster care system, indeed, may be one way in which Aboriginal leadership and addiction specialists can begin to mitigate the potential impact of the hepatitis C epidemic in their communities. Next slide, please. This is a picture from an article in the Vancouver Sun highlighting the findings of the hepatitis C study, and certainly speaks to the messaging developed by our media committee within the partnership. Next slide, please. Another important study that came out in 2011 in the Canadian Medical Association Journal was factors associated with transition to injection amongst Cedar Project participants. Transition to injection is an indicator of extreme vulnerability. Very few studies have addressed the issue because they focus slowly on the situation for people who only inject drugs. But one of the unique things about the Cedar Project is that we have participants who have not yet transitioned to injection drugs. They only smoke drugs. So this paper was looking at risk factors for that transition. In total, 19% of participants who were only smoking drugs at baseline transitioned to injection drug use between 2003 and 2007. So approximately 11 participants per year were transitioning to injection drug use. Young women in this study were 2 times as likely to transition to injection drug use. And if those women were involved in sex work, the risk for transition to injection increased by 4. As a follow-up, we did some work up in Prince George in a talking circle with girls who were in the office, and the tenor of the conversation was a real fatalism surrounding injection drug use and its inevitability as being part of their lives. They spoke about the few resources available to help with parenting, reducing harms of injection and sex work, and also the pain involved with unresolved grief and unresolved trauma. Indeed, there's very few resources available to address how we can prevent these kinds of transitions, especially up in the north. Slide, please. Sorry, this slide just highlights the last, what I was just talking about. Next slide, please. So last year we published a study in BMC Public Health Journal that once again looked at hepatitis C infection. And this time we were interested in identifying factors related to risk of infection over time amongst only participants who reported injection drug use. Slide. We had borrowed an idea from a previous study done in Australia that looked at the risk of HCV infection amongst participants who had been injecting for over 5 years, so more veteran injectors. Those had been injecting for 2 to 5 years, and those had been only injecting for less than 2 years, so relatively recent transitions. And this was of particular importance given what we know about the time of transition as being the riskiest time for those young people. Because they're new into injection, they can make more mistakes with regs, tend to be doctored more, to be second on the needle, and to not know much about how to maintain their veins and vein health. In this study, we found that on average, 26 new cases of hepatitis C per year were happening amongst Cedar Project participants who'd been injecting for less than 2 years. And again, young people involved in sex work were 55% more likely to become hepatitis C positive. Next slide, please. This is just a Kaplan-Meier curve that shows the dramatic increase of risk amongst those who'd been injecting for less than 2 years. And I just want to also note that we suspect there is significant survivorship bias in this result because the participants who were hepatitis C negative at recruitment and who were eligible for the study, and also for those who were hepatitis C positive were left out of the study. So the highest risk participants were the longest using individuals, leaving the lowest risk groups for inclusion in the analysis. So there is some flaw with this model. However, the transition, the risk shown in this curve is dramatic and certainly shows how extreme the risk is. Unfortunately, we do know that very few of our participants actually get or seek hepatitis C care. Next slide, please. I just want to say before we go that this year we have several articles coming out, 4 of which are in press at the moment, so keep your eyes out for them. We have 2 papers looking at sexual risk and condom use, a paper on the implications of policing policies on Cedar Project participants, and another paper addressing the rate of sexual assault and rape amongst women in the study. So I'm now going to pass the presentation on to Kofi Christian.
Thank you, Margot. Wow. What a great image that is there.
Hello?
Wayne, over to you.
Yeah, before I begin, I just wanted to thank Vicki and Margot for the presentation. I think, as you can see, the Cedar Project, I've been involved with it for about 8 years now, and as one of the investigators, it really is talking about giving a voice to young people in this study. And I think the biggest issue that we're encountering and what we see in terms of the study is what's in front of you. You know, it's called the moose in the room. Like you always talk about the elephant in the room. Well, in Indian country, it's a moose. And so it's really important is the issue of child welfare and sexual abuse and how the participants that have experienced this childhood sexual abuse, you know, the issue around the average age being 6 years old, and that 65% of the participants have been taken into care at some point in their life, and the average age of taken into foster care is 4 years old. So if you look at these statistics and think about them in the context of the residential school, they'd be very similar to the sort of the numbers, if you will, of our parents and grandparents that went into the residential school system. So I think it's really important to understand that Cedar and what we're doing is in the next generation really talking about the intergenerational impact of the residential school in terms of infectious disease, HCV and HIV. And in the context, I think that this is something that's not being talked about, and I think we really have to begin to speak and address this issue in Indian country, and it's really quite important. Could I have the next slide, please? And I think just speaking to you know what I was talking about, what we're seeing is that our young people are coming at age at a time when our families are really healing from the traumatic effects, if you will, of residential school. And we know that the legacy of residential school, that even though it's kind of been talked about and the Prime Minister made an apology, I think in 2008, is that there are a lot of our people that still have a lot of hurt and pain. As an example, right now, the Truth and Reconciliation is doing a hearing in the Kamloops, the residential school in Kamloops. And most of the people that are there that are speaking their truth and the pain that they suffered are really the elders. A lot of young people are not really involved in that process. And I think that the impact of the Truth and Reconciliation is that they have to find a way, I think, to acknowledge the young people and the intergenerational impact. And I think it's really important that our young people are, you know, really disproportionately represented, you know, in terms of sort of needle exchange, sex work, and newly affected with HIV. And I think we have to really think about this, that it's a direct result of the intergenerational public policy of the residential school system. You know, the policy of the federal government to kill the Indian and the child. And I think if we think about that as the public policy, and we think into the child welfare system, what's called Directive, I think it's 20-1, of where you have to be in care so that the agency can actually receive money to take care of children. If you look at the numbers, there's more children in care of the state right now. I think it's something like 30,000 versus when the residential schools operate at their height. So the cycle still continues. It's not the residential school, it's the child welfare system. And so our communities, I think, have reacted to what's going on, you know, with a lot of shame, embarrassment related to stigma, internalized racism, and homophobia, especially around the issue of HIV. People think that it's you know, a homosexual issue, but it's not. It's across boundaries. It's in both segments. It's not just with that population. I think we have to begin to talk about it. And I think that's what this study is all about, is giving voice to those young people. And I think it's really, really important. Could I move on to the next slide? You know, there's many challenges I think that we're facing, and I think the biggest one is how do we begin to address the issue of creating knowledge around how to deal with childhood sexual abuse at an earlier age. If we're seeing that in the study that has a direct relationship to the the sort of HIV infection rate, HCV infection rate, and what's happening in terms of the result of the residential school, we have a big issue. And I think the biggest issue is the silence, and the leadership has to stand up and say something about this stuff. Simply because in the vacuum of nothing happening, the status quo continues, and I think that's the issue for us. Could I have the next slide? What we're gathering in terms of the knowledge, and I think it's really important. I've really been an advocate that research without action is just research. And evidence-based research, as we know it, and our elders tell us this, is that evidence-based research tells us what we already know. And I think you'll hear that over and over again. You go into Indian country, the ones that are quite knowledgeable, they'll say, well, evidence-based research, what it tells us is what we already know. So if we understand that as a concept, we can enter that, sort of the research, sort of evidence-based research, but what do we do after we do the research? And so really a big part of this is what you see in front of you. How do we take that knowledge and translate it into advocacy and public policy, and how do we begin to change things? I think one of the key things in the North, there was a declaration, a resolution, the Northern HIV Task Force was developed, and a strategic plan for HIV/AIDS in the North. And the chiefs endorsed that. It was done publicly. They have a person that chairs that group. And I think it's really important, and again, other resources in the North, the mobile van. We've been making a number of presentations to communities, leaderships, and health service agencies across the country, not only in British Columbia, but also across Canada, because it's a Canada-wide issue, this issue. We've been doing lots of publications, commentary, and briefing notes. We've asked upon and called upon at different times to provide for leadership, different aspects of what's going on at the Cedar Project. One of the most important things that happened just recently in the North, they held a learning potlatch, and the keynote speaker was Sheldon Kennedy. I don't know if those of you have watched the media, but he's actually come out and talked about his childhood sexual abuse when he was a hockey player, when he was Coach James, and also you've seen that Theron Fleury also has come out and started to speak about this publicly in terms of the laws around pedophiles. So the learning potlatch in Prince George that took place, I was able to witness that. And probably the most powerful thing that came out of that was the young person that stood up and spoke about her experience with Cedar as a participant and what it meant for her. Not only for her, but also for her children, because what it did, it gave her value as a human being. She felt like she was not stigmatized, she wasn't treated as an outsider, that we supported her in such a way that she could tell her story without blame or shame, and she could speak her truth. And she spoke up and said this publicly in the potlatch, and it was a very powerful moment, because she was not only speaking for herself, she was speaking for a lot of other participants in the study. Is that I keep saying the numbers are more than just numbers, they're our relatives. So I think we have to really understand that. So that learning potlatch was really quite an important process. We look at community engagement events, and I understand that we're looking at a video project in Vancouver. And probably what we're really beginning to try to address is how do we influence the decision makers and influence policy in this area. One of the biggest issues we're having with the public health system right now is anonymous testing for our Cedar participants. We're looking at, we've talked with Dr. Perry Kendall, and we're looking at ways that we can actually have this, because we're having issues with how they're trying to access information, confidential information for the participants, and we really got to be clear about that. In this province, anonymous testing does not exist, and we've had incidents, 2 or 3 incidents now, where we've had to interface with the public health system, and it really has not been good for the participants. And also how the other government agencies, specifically MCFD, because of what they call red flagging people in their system, if they come into the Cedar Project, they try to find ways to gain access to that information. I think it's really really an important part, anonymous testing for our participants. And harm reduction services in the north and what's taking place there. And we're really looking at what's called a Child Advocacy Center. We're actually preparing to make a trip to Calgary because Sheldon Kennedy in Calgary has set up a center where any sort of interface in relation to childhood sexual abuse, there's a whole process set up. We understand there's a number of these centers in British Columbia, but there is no Aboriginal voice in them. So we're looking at ways and means that potentially we can set something up and begin to find a way that we can begin to advocate when this becomes known in terms of the legal system and how we can actually work with the young people. Could I have the next slide, please? And I think this is really about, the issue is about how do we support the resiliency and strength? How do we begin to understand what our young people are doing in terms of the use of drugs because they're in pain? And how do we support their resiliency? Because one of the things that's really important, we have to begin to think about being strength-focused versus focusing on people's weaknesses. And I think we talk about it in terms of the addicts and alcoholics and those things. We label people. I think we have to begin to look beyond that and begin to look at a holistic way that we can actually begin to understand and support the resiliency and the strength of these young people. Because they're transitioning, I think, and one of the things that happens in sort of traditional sort of practices, if you will, if people are actively using and or either drugs or alcohol, is they're barred from sort of accessing ceremony, and specifically for very specific reasons. But I think the issue of abstinence-based programming is prevalent in Indian country. We have to begin to think about harm reduction. How do we begin to introduce harm reduction into the spectrum of care for Aboriginal young people? It's really, really important. And again, we have to understand that the young people who are actually using drugs, they still want access to culture and tradition. It's important to their healing. Because the biggest part is they've been dispossessed from who they are as Indigenous people or Aboriginal people. They have no knowledge because their parents or grandparents have not taught them, or they have not lived in their homes or were raised in non-First Nations and homes and environments. And I think it's really, really important. And I think the issue of cultural resources and traditional sort of practices, and how do we deal with the issue of access because of the issue of abstinence, and how do we reconcile those different points of view? I think that's really important because, I was the executive director of the Round Lake Treatment Center for 14 years, and the promotion is abstinence-based. That in order to enter healing, if you weren't clean and sober all the time, that you have failed. And I think we have to begin to understand that healing and abstinence is part of that process, because people have many slips and fall. They pick themselves back up, and we have to begin to know how to introduce harm reduction into the treatment system, if you will, in British Columbia, so that it's not something that is looked at as needle exchange, and those things are important for young people who are being accessed or available for them. It's really important. Next slide, please. And I guess the bottom line is that, I know there's a number of different people from around the province on this video conference, whether you're on dial-up or whether you're on the actual video conference. But really the numbers, if you think about what we're doing here, Vancouver, Prince George, and small communities in the interior, it's a snapshot of British Columbia. And we know that Hep C is a precursor to HIV. And we see that on the rise. If we don't begin to address this in a meaningful way in terms of prevention programs for our young people and start introducing harm reduction programs in our communities, we, in terms of the healthcare system, we're going to have problems 5 to 10 years from now. And I think this Cedar Project is a call to action for all our communities so we can reduce harm in our communities. We really have to know that our youth are struggling, and we have to find ways to support them in whatever way we can, because addiction, unfortunately, it still is an issue today, but more so, I think it's gone underground in some ways in terms of the hard drugs, whether the injection drug use, the issue of crack cocaine, heroin, and those things that people really don't talk about, but those things are in our communities. And they're in our communities simply because our people are transient. They move around a lot. You'll probably see, and Vicki may speak to this, is that what we're finding here in the smaller communities, they move around quite a bit. They move from the small communities, they're in the reserve communities, into the local towns. They move into Kamloops, they move into Vernon, they go to Vancouver. So we have a very transient youth population. I think we have to begin to address these, and I think we have to do it in really looking at prevention programs, and that's what Cedar is about, giving voice to our young people. And I think it's a call to action. So again, thank you. If you have questions, we've got
Patient.
we have people available to answer them. Vicki, Margot, and myself. So thank you. Hello?
Chief Wayne, thank you very much. That was awesome. I really appreciated your call to action and advocacy, really critical. And there's so much that is in this project that you are addressing that are intertwined. It's very complicated, these things. And so I'd like to just put it out there for questions. We have quite a few people on Adobe Connect and out in the community. If you have any questions on video conference, just unpress your mute button and go ahead and ask. And on video conference, I think that would be great to hear from you. Waiting for the questions. We've got quietness. Okay. We've got a few people asking questions. So I have a question. You talked about having a community board with whom you make decisions with and decide on what your next steps are. And so I see that some of your next steps are, can you just talk about those and then how you actually approach that? Specifically, maybe Chief Wayne or Vicki or Margot, do you want to answer that question?
Maybe I could try to address it. I think one of the things for next steps and how we engage a partnership is, like Vicki talked about, the governance model is we meet on a quarterly basis, and we have our partners involved in that process. So everything we do in terms of next steps, we bring it before the partnership and we have a dialogue and talk really about what are we actually going to do here. And with that engagement, then we talk about how we're going to move forward. And so I think that really is about a participatory kind of a process. The elders are involved in that. Myself, I said the other chiefs that are from these communities, the Salcombe, the Lakes Division, but that's how we do it. And it might seem cumbersome, but it really gives voice and gives what you would call a community voice to the data and the interpretation of the data and or the design of questions, and it's really critical. And it is maybe a little longer of a process, but the ownership is with the communities, and I think that's what's really critical.
Fantastic. Okay, I have a question here. Did the Cedar Project allow youth that were actively using to participate in the sweats or the paddles? And is this what we should be doing for our communities? That might be a question for you, Chief Wayne or Vicki.
I can take this one. Any cultural activity that I have participated with any participant in the Cedar Project has been up to the discretion of the person that holds that ceremony. I don't have any control over that ceremony. I have talked to our elders about what it is okay to do and follow their teachings. So say with the old man I go and sweat with, his requirement is that you be 4 days clean before you sweat. If you haven't been 4 days clean, you can still come out, and he's had people be doorman in ceremony, or the women are going and helping cooking it and prepping and stuff. They have told me when I do different things, we go out, there is cedar up here in Prince George. or we go out and pick fresh cedar. We try to do that every year to put over the door to cleanse our space. And for participants, as long as that morning when we leave, if they're not under the influence, then they're more than welcome to come out. And then they learn the process of picking, because cedar is one of our medicines. So they learn the process of what it means to give a tobacco offering, our prayers and stuff, and how to pick it and what to look for in different things. So depending on what the ceremony is, I've just gone to whoever holds that knowledge. I'm really young and naive, and I don't have any of those traditional teachings, so I can't be the person to go, you have to do it this way. It would be different if this traditional leader and this traditional leader, in terms of those ceremonies, got together and said this, but in terms of no. So there are different things. If I know I can take kids to this one elder, and even if they're under the influence, she will smudge with them, because her teaching and guidance is that that's what the Creator wanted at that time, and even though they're under the influence, they may not get as much out of it as when they're completely clean, but there is still, that might be something that's going to start them on that path, and who is she to step in that way? So it really depends on the teachings you have. So I'm going to mute it.
Thank you. Crystal, do you want to start answering the question? I have to apologize. I have to run out right now, and I want to thank you for what you are doing. Crystal is going to stay here, though, and ask some questions that are coming up right here. So I apologize. Thank you for your teaching. Just a few minutes. Okay. Do you want to ask that question?
Sure. Okay, here's another question on Adobe Connect. Is there any dialogue with the Interior Health Authority regarding the recommendations from the project? I guess could be Christian. Could you do you know anything about that?
What's actually happened to date, we haven't had any interface with the health authorities in terms of actually the recommendations and the data. It's something that we're talking about in sort of the next round, sort of next steps. How do we begin to interface with not only the health authorities, but also the First Nations Health Authority, make these presentations to? Because I think it's really important that the First Nations Health Authority is also aware and understands this. It's a province-wide issue, and how can we begin to look at prevention? So we haven't had formal sort of processes yet.
Thank you.
I just wanted to say a quick. Can I add on to what Kupti said?
Yes.
With our Chase office, we are in the process of reviewing the data that we have collected so far with our young people in that territory. So specifically about information regarding participants in the Secwepemc territory, that will be coming up soon, but it hasn't happened yet, Wayne, you're right.
Okay, thank you. There's another point on Adobe Connect. Grace makes the statement, the Musqueam Indian Band in their newly redeveloped safe home is looking at all options in training our staff and Musqueam community members. We would definitely be interested in the discussion regarding the Child Advocacy Center. It is utmost priority to break the cycles of abuse. We do not want to continue with systems that do not work for our Aboriginal communities or that inflict more trauma upon its most vulnerable members. To respond to that.
I think Kopi Christian would probably be the best person to respond to that comment.
All I said was a good one.
Yeah.
You know, I think I really do believe that what they're talking about is how do we begin to do that, and as we evolve and develop the Child Advocacy Center, we want the First Nations and Aboriginal community involved in that process. So we will keep people apprised. I think we have an active website for Cedar for the project. And this is one of the things where, like I said, once we come back from Calgary, we'll have a better plan of action in place as to the specifics of what we're going to do over the 6 to 9 months. Thank you.
Is there any comments or questions from anybody in the rooms on video conference? Just a couple more minutes. We have somebody typing on Adobe Connect. We're just about done here for the afternoon.
With some asinine question.
What does asinine mean?
Ridiculous.
Oh. I just laugh like I know what you're talking about.
I do that all the time.
All the time. Me too. I can't even help it.
It was like that after the first time Patty said paucity. I was like looking it up on Google. What does that word mean? And how do you even spell it?
Okay.
A lack of.
Okay. Okay, we can hear your conversation up there in Prince George. Thank you.
Oh my God. I am so sorry, everyone.
That's okay. Oh, that's what we needed. We needed a good laugh. So Grace has offered the Safe Home Manager her details. So I'll make sure that Coopbe Christian and the other participants are actually connected with her, that we make that connection. And it's definitely a part of the partnership that Coopbe Christian spoke of earlier, is building those partnerships across the province and with other communities. So that's great. Thank you, Grace, for that. Jocelyn, we do have another comment here. Is adding to Eleanor's comment, how would her question apply to an education setting with Aboriginal and non-Aboriginal contexts? And Eleanor's question was, did the Cedar Project allow youth that we're actively using to participate in sweats and paddles? Is this what we should be doing in our communities?
I think we already answered that one.
So she was adding to it.
Oh, sorry.
She was adding to the comment, how would her question apply to an educational setting with Aboriginal and non-Aboriginal learning contexts? I think they're just looking for some sort of feedback and maybe just further direction. Should that be allowed, because if they're working with both Aboriginal and non-Aboriginal, I'm not sure if they are First Nations themselves or Aboriginal. They're just looking maybe for some further direction.
This is Vicky. I have to apologize. I thought I had mute on. I'm so sorry, everyone.
It's okay.
One of the only recommendation I can have is that the people who hold those ceremonies have to be true to themselves, and have to talk to each other around that. Maybe Coopde, you can add to this. But there are some people who are sweat lodge holders that, even if you're on the methadone treatment program, so if you're taking prescribed methadone from the doctor to help you stay off illicit opiate use, won't allow people into their lodges if they're on that. Some people do allow people on methadone into their lodges. It's everybody's teachings are different, and I think it's almost about how people interpret their teachings. Dr. Martin Brokenleg, I saw him present a couple of years ago, and he made a really valid point about how we do interpret our teachings, and that you don't go in with jewelry, that you have to take that jewelry off, that metal shouldn't be used in the ceremony. He goes, but yet we use pitchforks to pick up our grandfathers and grandmothers to bring those in for the ceremony. So I can't tell a person who has those teachings what to do, and I'm sorry if I don't have a clear answer, and maybe Coopde, you can expand on this.
Did you mute it, Vicky? Just checking. I think that when we talk about an educational setting versus a ceremonial setting, there's two different environments. We have to be clear that what we're talking about, when you talk of like educational setting where you have Aboriginal, non-Aboriginal sort of mixing, the same, if you will, protocols don't apply because it's not a ceremony. As an example, I think we talk about people that are actively using, and there are ceremonies you can actually do to brush them down, as an example, a smudge ceremony and those kinds of things. So I think it really, again, like what Vicky's talking about, it does matter who is actually performing whatever that is in the public school system. But understanding that that's what it is, it's an educational system, it's not designed as a ceremonial sort of process in the school. Where a sweat lodge is totally a different environment altogether. So I think we have to keep that in mind when we think about these sort of approaches. And I think it is, like Vicky says, the teachings that people have been giving and how they've been given, instructed, how they work with people in those ways, because there's a reason why people that are actively using don't enter certain ceremonies, and it's spiritual processes that are impacted, so we have to understand that. So I think in the educational setting, it is a different environment, and I think we've got to be clear that what's happening is that through those smudge ceremonies specifically, you're probably instructing and teaching people about something that they don't know. So I think it would be different, but it would depend upon who is actually doing that smudge ceremony. Thank you.
Some of us are turning our mics on and some of them aren't. Some of us aren't. So there is one more question on here before we wrap up. Priscilla's asking, are there any examples of partnerships happening between more than one First Nation and the Health Authority?
I'll try to answer this one.
She's typing some more, Cookby, if you would just...
Okay.
I just asked her. Okay. Thank you. Technology. Under pressure, must be. So she states, so to clarify, meaning that if there are any further research projects, will there be opportunity for rural First Nations communities to partner to conduct a similar study?
At this point, I'm with the Cedar Project, I'm not sure that we're looking at expanding, but if there is new sort of interface with health authorities and research, there probably is, I think, within the circle of researchers, people looking for communities to partner with, much similar to what we've done with the Cedar Project, where the community is fully engaged, where the community actually runs by the OCAP principles. I think that's really important. So I think there probably is opportunities. I'm not sure. I think Dr. Patricia Spittle, who's the actually in Uganda right now, when she returns, she probably can respond to this question. She's probably very well aware in the research community what is taking place. So that's definitely a possibility.
Thank you. Okay, one final comment. Elena is actually typing. At this time, I just want to thank all the participants, both on Adobe Connect and on our video conference unit. We had upwards, I believe, of 27 or 28 participants on Adobe Connect at the highest point, and I believe we had about 7 sites on video conference. So there was a combination of different people in each of the rooms and participating today. So thank you for everybody participating today. And in addition to that, I guess, everything that was spoken about today definitely hits home. And at Cookby Christian, as you know, what my family has experienced over this past month, and the losses in the communities, not only in the Swiftmik Nation, but the Okanagan Nation, with relation to not only mental health illnesses and their direct correlation and links to the drug use and the alcohol use, that, you know, there are losses of our young people that are taking place across this province, and the attempts and the frustration. I heard you speak, or I heard somebody speak of the frustration with the system. Well, I, you know, had the same experience just recently, as recent as last week, and, you know, I seen the young girl who took her life had that same frustration with the mental health and the addiction system, right? Wanted the support, but there was always that requirement that she had to stay clean and sober, and frustrating that she wanted the mental health system but couldn't get through to the people she needed to when she needed them. So with that being said, you know, a piece of it is, you know, she was my adopted daughter, and they have formed something that's called the Gucci's Promise, right, which has become my new what I will dedicate, you know, part of my life to, is bringing awareness to that there is mental health services available, and the work that there are people out there willing to support all these young people. And there's a resource list of telephone numbers at that site. It's a Facebook page now, and it's called the Gucci Promise. So just supporting all the work that you're doing, because you're all doing some really fine work based on research, you know, and realizing that you've put some very long hours, probably could be on the side of your desk, into these projects. And it's you know, nice to hear about the work behind the scenes and how it's going to pull together, and it's not something that's just going to drop, that it's an ongoing project, and there's people dedicated to helping our young people. I appreciate that. So Catherine, are those messages to you from Elena? She is still typing. So if there is any closing comments from Vicky, or it could be Christian, or Margot here, I'd just like to wrap it up. Okay, so Elena, she suggests contacting the Canadian Aboriginal HIV/AIDS Network, recently designated as a community-based research center. In addition, suggests looking at the Ministry of Health's Hope to Health framework, which articulates the meaningful engagement of First Nations and the provincial expansion of treatment as prevention. I am the HIV/AIDS project manager with the FNHA and can be contacted. And then she has left me her email, which I will also forward these connections to all the presenters today.
Closing comments?
Yes, closing comments, please.
Okay. I just want to say that I really do appreciate this opportunity for all of those that are online and those that are on the video. I think the key message, and I think, Crystal, you talked about it, really is about we have to stop talking, we've got to start doing. And I think that's where we're at with the research we've seen, sort of what is there. Now we've got to start beginning to put public policy, putting some action plans in place. Because at the end of the day, you know, what's happening is our young people are still reaching out, and they're not finding what they need in terms of processes. And I think we have to find ways to create those for them. And sometimes it is simple as just having a conversation. And I think we have to be mindful. Sometimes it is not within the system where the help comes from. This help usually comes from on the street, because if you talk to the Cedar participants, a lot of their support system is with each other, how they support and help each other. And then people like Vicky and the people that are working with them on the front line, a lot of the time is really spent listening to them and giving them direction and giving them sort of referrals to different processes. So it really is about taking action. And again, I want to thank Vicky and Margot for you know, the contribution, the participation, and all the questions that we had. And it's been interesting doing a presentation like this, but I didn't have to leave home. That's awesome. So, Kukshem, thank you all.
Vicky, do you have any closing comments up there in the north for us?
Hi everyone. Me too. This is my first time doing a video conference. It was really weird not not being with everybody. But pretty neat because I'm a homebody and was really excited to stay home. And I want to thank everybody for tuning in and taking the opportunity. And you can get my email from the Learning Circle if you want to stay in further contact, or the person from Musqueam that's really interested in the Child Advocacy Center. And once again, I apologize. Nancy, the person I was referring to, is a colleague who I thought would tease me with a question. So yeah, and everybody just got to hear that. And anybody who really knows me knows that there usually isn't a day that goes by that I don't make an ass out of myself some way or another. So yeah, in my language, Guyana Kichi, thank you for being here with us today.
Thank you, Vicki. I think we all needed a good laugh. It was meant to be. Do you have any closing comments here?
Sure. I just want to thank everyone for the opportunity to share here at the Learning Circle, and I'm just humbled and honored to be part of the Cedar Project. I learn something new every day, and humbled by the experience. So thank you.
Thank you all for joining us. And here at the UBC Learning Circle, we would love to have a follow-up session just to hear the outcome to the future meetings that the Cookbee Wayne has talked about. So again, thank you to all the speakers and for everybody participating today. And if you haven't joined us or followed us on Twitter, we're on Twitter, and we can be found on Facebook as well. Just Google search the UBC Learning Circle. So thank you, everybody, from here in downtown Vancouver. Have a good day, and thank you. Hi, Chka. Cook's Jam. That's a wrap. That's a wrap. That's a wrap.
That's a wrap.
Thanks, Stephen.
Bye, everyone.